Good afternoon. We're here at ASH, and I have with me today Dr. Rafael Fonseca, who is the Chief of Internal Medicine at the Mayo Clinic in Scottsdale,
Correct.
as well as a longtime myeloma expert and friend. I've known him for many years. And Rafael is here to talk to us about some very interesting research that you're doing with claims databases and looking at outcomes of myeloma patients.
Sure. Well, first of all, thank you for having me here. It's a pleasure to be here with you. So one of the studies that we're presenting here, it's part of what people call RealWorld, which is very interesting. What people are doing is just using big data, and with that, trying to address some important clinical questions. So the one we have here actually tries to address the question of maintenance, and we did it in a way that we actually got a hold of one of these databases from insurance claims. Mm-hmm. And we first asked the question, okay, well, let's see patients who are newly diagnosed, ICD-9, ICD-10. And of course, because the insurance pays for the treatment, you can see, let's get claims for lenalidomide, Bortezomib, Dexamethasone. And then subsequent to that, then within a time frame, a claim for a stem cell transplant. So before you know it, you have a cohort of patients that's newly diagnosed with uniform induction with VRD with a stem cell transplant.
Sure.
Then we ask the question, okay, let's look at claims post-stem cell transplant, but now for lenalidomide. So you actually have groups of patients who are in maintenance and groups of patients who are not, and all through the claims database. And then we take it one step forward and we go, okay, of all of those patients, some of them on, some of them off maintenance, at which point do they have a subsequent claim for a new drug, an injectable, say like Daratumumab, like Bortezomib, Velcade again, and what you find is with that, you can actually determine time to next treatment.
Right.
Now, it's not quite like progression-free survival, but then what you find is that the time to next treatment is a mirror of what you're seeing in the phase 3 clinical trials. Really? And so we're looking at essentially 52 versus 23 months, and most of the trials are 53 versus 23. There's another study that was presented by the MRC9 here. So the power comes in the numbers. I mean, of course, real-world data sets don't have the purity or the nature of the prospective trials because, this is real-world, but they have the power in numbers. Yes. and the ease with which you can ask some of these questions. So at this meeting, if you do a search for real-world, it's just incredible the number of abstracts that are out there. Now, I know a lot of my colleagues, and myself included, would consider the phase 3 the standard of care. Sure. However, this new research gives you the opportunity to ask very quickly important questions that you can validate later, or some of them could never be done in a phase 3 clinical trial. So if you wanted to know a rare side effect in 10,000 myeloma patients, you would never run a trial like that in 10,000 patients, but you could get it through real world data. So it's an exciting area of research.
Well, and also I guess it's great to confirm what it
Sure.
is a prospective phase 3 trial and know that what is being used now is what was tested in those trials, and it's
Sure.
consistent.
Sure.
It also is good that the integration of these newer therapies are being used, right? And
of course
they're being applied. Of course, there's a lot more coming. So I mean,
Sure.
these kinds of research will become even more important as the newer agents get those newly diagnosed indications, assuming they do. And then the other factor that'll come into will be also the cost of therapy, and
of
how
course.
that factors
Of course.
into all this as well, because we're going to be facing some really tough questions down the road about that.
Well, I mean, so there's a lot of questions, a lot of super important points, and a lot of things that can be addressed with the real world data. So first of all, you can look, and in fact, in this study we report this, it's a poster that's tonight, you can look at subsequent treatments. Mm-hmm. So you have a glimpse of what's going on, and you have a glimpse of what's happening. Now, we've used a similar data set in a previous study. We published that in leukemia earlier this year. Now, that study was much larger. We didn't specify of a specific treatment, but you just looked at myeloma from the time of diagnosis until the time of death. Now, how we got that was by cross-referencing this data set with the Social Security Death Administration. So you can run Kaplan-Meiers, and what you can do is you can actually estimate survival for patients, and I'll get into cost in a second. So as you start putting all of this together, you get a very clear picture of what happens in the community. Now, in myeloma, we're incredibly fortunate because we have a biomarker that tells you if what you're doing is working or not. Mm-hmm. And if you do, you keep going. So a study that says, well, it's an improvement of whatever, 6 months, 3 months, whatever, it doesn't really matter because at the end of the day, it's an N of 1. Mm-hmm. So in myeloma, is this iterative process where you know what you're doing, whether it's working or not. And 98% of the cases, there's some that are a little bit harder, but 98% of the cases. So there's increased value by knowing that there's a benefit. It's a little bit harder if you think about immuno-oncology, right? The checkpoint inhibitor, maybe the long term. Right. It's sort of the group benefit that makes you do that. It's kind of like going to college. It's better, but you don't know individually if you're going to be better off. And but with a claims database, you can also ask other important questions. So one of the ones would be with maintenance, right? Some people might say, well, I want to be very, very strict. I want to be a purist. I won't give maintenance until I know that there's an improvement in overall survival. Some of the studies are showing that. And one of the common arguments would be, well, how is that different in doing maintenance versus maybe providing lenalidomide at the time of relapse? Mm-hmm. Well, one of the things that real-world studies will show is that you cannot assume you're going to get to that option. Because oftentimes if you progress, you may have the opportunity to do that, but sometimes a person may develop renal failure, may be very ill for other reasons, so they may not see that subsequent line of therapy. Mm-hmm. And this has been documented quite well. There's an attrition as we go through lines of therapy. So the question is not, okay, what's better, A followed by B or AB now or nothing or B now, because then that can be addressed with the real world. Lastly, about cost. With a claims data set, you actually see what the dollar exchange was. You don't see the sticker price. Mm-hmm. So everyone talks about the CAR T cells and how much they're published at and how much they're going to cost. No one knows how much they're going to cost because it will go from the company through the PBM and to the insurance company, and there's significant reductions in price when it comes down to the rebates. But in myeloma, you start thinking, okay, think about drugs. Okay, how much of the drug is being dispensed and at what price? So actually we included that in that leukemia paper. And we showed, of course, like everyone else, we're concerned with the rising cost of drugs, but also the rising cost of everything else. It turns out that it was at par, and some areas were rising even faster than the drugs themselves. Hospital stays, and we do all this testing with PET scans and bone marrows and all what we do. So that all adds up to the care of the patient.
Interesting. Really,
so
really
thank you. I think it's fine. I am thinking that real-world data will be as disruptive to clinical research as social media is now to traditional news outlets. Everyone's a journalist nowadays, right? Yeah. You have an iPhone and you're a journalist. Well, social media will not be a one-off, but it's just the power of numbers through big data analysis.
Yeah, and the real-world data is, I think, will become more and more important from a uses perspective, as these companies will probably take the model of some of the European countries and having more restrictions around the accessibility of drugs and things like that.
Sure.
But based on the real world data, they will make that access good.
Well, you know this about me. I hope we never take the route of the European countries, with all due respect to my European colleagues, because then we start including questions about, is it worth paying for it?
Right.
Mixed with a question of whether it's the right medical thing to do or not, and from a patient perspective, I wouldn't want to be in a scenario where an externally dictated threshold for a maximum pay. Now, we all live in the real world. If I had a pill that would cost $1 million a pill, no one would buy that. But then there is a concept which is often used as a derogatory concept, but it's not derogatory. In fact, it's meant to define precision, which is what the market will bear. Mm-hmm. Where the market will bear is, of course, the companies could price their drugs at 3 times what they're selling them right now. But there's got to be a point where there still is a willingness to do that. And this is a much larger discussion, right? Because then there is a public perception of what's appropriate. When you're a purchaser of an insurance, are you really thinking, well, 30 years from now, do I want the myeloma coverage for this or that? You're not thinking about that. Or if you're a payer, are you going to realize the savings or maybe you do if you're the government, but traditionally government systems pay less and have less access than private insurance systems. So it's a very complicated topic. We're all trying to talk about it.
Thanks for coming by. I really appreciate you having this discussion. It's very, very interesting data, and I'm sure there will be more coming.
My pleasure, and of course this is important for patients, and we all owe it to them.